Well, what Joe and I talked about before talking about was particularly this time of year is acute exacerbations. A lot of new data, not really new data, but a lot more recommendations to come out, particularly with the release of the 2023 global initiative that came out last week. And what I thought I'd do is just review over some key points about this and then open it up to questions for the last 35, 45 minutes or so. The flare-ups are, what's an exacerbation? Well, if some people say it's an exasperation, I've heard that term used a lot, but it's really called an exacerbation. And it's what it really is, a flare-up of your symptoms. I bet you most of you on the call have had an exacerbation at least once, if not many times in the past. And we'll go into the symptoms in a few minutes, because there is some information from the COPD Foundation that's kind of interesting, that me as a healthcare provider is only half of the equation. I hate to say it, but you are, as a patient, are the other half of the equation, if not 90% of the equation. And we'll get into that in a few moments. Usually caused by an infection, usually a virus. It's an adenovirus or an RSV virus or some type of influenza virus that triggers it. Often not caused by a bacterial infection, although the typical call to the primary care providers is, I have an exacerbation, I want an antibiotic. And that may be good, may not be good. I'll go through some of that information in a few minutes. It could also be due to just something irritating, some irritation that you inhale, whether it's air pollution, pollens, perfumes, other types of, any other type of irritating substance to you that causes essentially an inflammation in the lungs and in the airways themselves overall. Let's see if I can, there we go. Well, how do you feel? How are you going to feel with an exacerbation? I would liken you to, or I would refer you to the COPD Foundation website or the American Thoracic Society website, where there's good patient information about all these things I'm going to talk about today. But what you have is more shortness of breath, increased mucus production, increased change in color of mucus, or if you have a cough, worsening of your cough or development of a new cough. Some of the other things that you may not think of as come along with an exacerbation are just increased fatigue and increased trouble sleeping. This has been what has happened with COVID, where people got a lot of fatigue, a lot of trouble sleeping, and also had fever and chills and cough along with this. Although when I say COVID, there's not really much information that COVID triggers exacerbations. And in fact, the other thing probably has happened over the last couple of years. We've seen in the hospital course in several publications that people in the COVID realm for the first 2 years had less in the way of exacerbations, and hospitalizations were less for exacerbations, probably due to other things not related to the virus, but due to some of the ideas that we have with hand washing, masking, and distancing that occur out there. But when you look at the symptoms, and this was from the COPD Foundation, and when you look at the symptoms, almost everyone, whether you're a man or a woman, almost everyone presents with shortness of breath. So, and actually more women present with chest tightness than do men, but you can see down here more wheezing, changes in mucus, more cough, increased fatigue, more use of your rescue inhalers, all in anywhere from 70 to 80% of people. So that's what you're going to experience, mostly increased shortness of breath beyond your daily shortness of breath. So many of you that have COPD have shortness of breath on a daily basis. It's when that shortness of breath gets worse that you should really think about an exacerbation or a flare-up. Well, how's it diagnosed? There's really no magic medicine, or there's no magic test to diagnose it. It's diagnosed on your symptoms. That's why I say you are 50 to 90%, I'd say 90% of the process out here, because your symptoms are going to define whether you are having an exacerbation or not. No particular tests are out there. A chest x-ray might tell you if you have pneumonia, but most chest x-rays, if you took all the exacerbations that people have, most chest x-rays are unchanged or without any evidence of infiltrates. So the best person to help identify an exacerbation is you. It's not me. It's not the testing I have. It's not a flu. It's not a flu swab. It's not a COVID swab. It's not a culture. It's really you and your symptoms. So I cannot highly emphasize enough that your symptoms are going to dictate whether you have an exacerbation or a flare-up or not. Interestingly, when you have an exacerbation, very few of you, less than half, actually call your healthcare provider. It's kind of sad, and there's a lot of reasons for that. But here, and this was again a study that was asking patients that the COPD Foundation conducted, that only half of you actually contacted your healthcare provider when something is wrong. You thought, well, I'll just get over it. It's a weekend. I don't want to bother somebody. Or if I call the doc up, they're going to think I'm crazy. Then they'll tell me to wait till Monday, or they'll tell me to go to the emergency room, God forbid. Less than 30% said that when they had symptoms start, they actually called their healthcare provider. And it was only, and 4% when you needed emergency department care, that you actually contacted a healthcare provider. So again, it's really the onus is upon you to know what your symptoms are on a daily basis and to know if they're getting worse or not overall. How do you treat it once it's diagnosed? Well, it's treated the same way you treat your underlying COPD in many instances. Inhaled bronchodilators are really the cornerstone of therapy, and they're the cornerstone of preventive therapy, meaning that most inhaled bronchodilators on the market today have been shown to reduce exacerbations going forward. So when the people were entered into the trials, they looked at the number of times they had an exacerbation, or the time to the first exacerbation, and all were improved with these aerosol with the bronchodilators. I'm not going to go into the specific ones unless there's questions on it, but almost all of the bronchodilators have been shown to reduce exacerbations. The key thing that you should be on, you need to talk to your primary care provider or your pulmonologist about which ones are best for you. If you're getting an exacerbation, when I say the inhaled therapy, if you can't use your inhalers because you're too short of breath, number one, you should have already contacted your healthcare provider in that instance and had a backup plan going, whether it's an aerosol treatment. Unfortunately, many of you might need, or some of you might need to go to the hospital to be treated. And if the exacerbation is significant enough, then certainly antibiotics. I mentioned antibiotics before, in that antibiotics are good for bacterial infections. They're not good for viral infections. And if your sputum starts changing color, and there was a study done 40 years ago now that showed if you had increased shortness of breath, increased sputum production, increased sputum discoloration, then an antibiotic given early on in the course does reduce the time that you're sick from an exacerbation. And as do steroids. So steroids in a short course, I don't know how many of you have been on steroids in the past. I'll bet you 90% of you have had steroids sometime in your adult life. But steroids really are a cornerstone to early treatment. But the treatment should only be for 5 to maybe 7 days. You don't need to have 2 weeks of steroids or 3 weeks of steroids. It's really a 5-day course was as effective as a 14-day course. So somewhere between 5 and 14 days are out there. And then certainly if you need to be hospitalized, or if you actually monitor your oxygen saturation, if you see your oxygen saturation declining, then that should prompt number one, a call to your healthcare, your primary care provider, and also to increase your level of FiO2. In the hospital, we're going to give you all of these. We're going to give you all 4 of these overall. Some people, when you're hospitalized, you'll need some type of non-invasive support, meaning a mask, either CPAP mask, or heated high flow oxygen that we can talk about if you have questions on that. Those are not really available to send you home. And unless you're using CPAP for sleep apnea, that would be something you would use in the hospital setting overall. Well, how do you prevent it? The best measure from getting over an exacerbation is never having one happen. And if you don't have one happen, then that's great. Certainly if you smoke, you got to quit. That's the biggest indicator out there, the biggest culprit for developing exacerbations. You want to try and avoid others with colds and flus, as John had mentioned before, trying to avoid other people that are sick. Herpes certainly, or shingles, will not be transmitted from one person to another necessarily. And it can be transmitted from the sores that you get, but that's pretty unusual overall. But certainly, and I think this is why in the COVID era, the last couple of years, we've seen exacerbations drop off significantly, because people were doing what? Hand washing. They were avoiding people. They weren't going out or going into any other crowds at all, wearing a mask, which, you can debate whether masks help or not. I personally believe that masks do help in this instance. And then I mentioned before, good hand washing. So trying to prevent yourself from shaking hands, hugging, kissing, anything like that. And then wash your hands. If you do have to do those types of things, then wash your hands afterwards. Getting the flu vaccine is important, the influenza vaccine, and I would say the COVID vaccine, although it'll be years before we know that COVID is implicated in worsening exacerbations. And then, as I mentioned before, appropriate use of your inhaled medicines. If you are using your inhaled rescue bronchodilator more than a couple times a day, then you need to be contacting your healthcare provider to make sure that this is not an exacerbation overall. And then most importantly, the action plans are set up. And when you get an action plan out here, this is the one from the COPD Foundation. It's only half of the one out there. To me, these are kind of, I think it's good to start out with one of these. But I think many of you will see, and I'd be curious to get your opinion, is can you do this on a daily basis? Are you going to every day for now and the rest of your life fill out a form like this? I think it's good initially, so you get some idea and get some, so if you say that I'm progressing and I don't feel quite as well and it's a day or so down the line, then have a certain action plan in effect, which will often be contacting your primary care provider and discussing with them what type of therapy they would recommend, whether it be additional inhaled bronchodilators, whether it be switching to an aerosol, whether it would be adding an antibiotic, or whether it would be adding steroids to your regimen. But this should all be designed way before Friday night at 5 o'clock when you're sick and you're afraid to call the doctor's office because you know that they will tell you to go to the emergency department in almost all instances. So work this out with your healthcare provider. And if necessary, take one of these with you. Just go to the website out there, the COPD website. The American Lung Association website also has a very good action plan. And to be honest with you, the COPD Foundation, they have an app that you can do this on your app and get almost instantaneous feedback into where you're looking at overall. And I put this in here. This is the copdfoundation.org, where they have a pocket consultant guide, and you can just get into this. Many of you are probably on the 360 Social, but if not, and you don't know where this is, just go to the pocket consultant guide on the app, and then you can get this on your cell phone and be able to track yourself on a daily basis overall. So in summary, then we'll open up all the questions out there. Know your risks. If you have COPD, if you have asthma, if you have any type of chronic respiratory disease, no matter what it is, whether it's interstitial lung disease, whether it is venous thromboembolism, they all put you at risk for developing exacerbations. I didn't talk about interstitial lung disease, although it's pretty much the same type of therapy that you really want to get yourself into following you picking up on your symptoms. And you really have to know your own body and your own symptoms. Nobody knows it better than you do. And along with that, not only look at and get an action plan, but really act on the action plan itself. And that includes involving your primary care provider, whether it's a nurse practitioner, a PA, your respiratory therapist, or the primary care physician or pulmonologist. I would work on an action plan with somebody that knows who you are, that when you call on a Friday night at 5 o'clock, you're not just told to go to the emergency department overall. A lot of exacerbations you can get over on your own. You don't need to go to the emergency department or MedFirst or MedExpress. And hopefully certainly don't need to be admitted in many instances if you get these earlier on overall. And with that, Joe, I'll let this slide up here, but I will turn it back over to you. And then I'll be happy to answer any questions people have out there. I haven't checked the chat, but I will go in and
yeah, I've been taking a look. I know we have a couple from John, and certainly I'll let him jump in, and then we'll let others jump in. John actually put a link in the to the pocket guide as well, which is great. The foundation has some fantastic resources, so I highly recommend it.
yes.
John, go ahead, man.
Yeah, Brian, just a couple things. First, thank you much for putting up the personal action plan. It's so important for everyone to take that. And you're right, no one's going to fill it out every day. But if you look at it each day for the first few weeks and familiarize yourself with it, then put it on your refrigerator. And if you're feeling off, then you go and you look at it and say, you know what, maybe now I need to call my doctor. One of your first slides showed women versus men with different symptoms of exacerbations.
Mm-hmm.
Every single one of them, every single one showed that women had more of the symptoms. Is there a reason for that? Men, I would think the women would tell the men that the men tend to complain more about maladies. So
Yeah.
I was surprised.
Yeah, it's almost similar to heart disease. Women who have myocardial infarctions or heart attacks present differently than do men. And you just have to be aware of that overall. Although it was helpful that 90% of both men and women presented with shortness of breath. But yeah, but I think that's more so if you are a man and you're a little bit more austere, or you're more reserved, so to speak, you say, well, it's not my COPD exacerbation. If you're more short of breath, it's probably coming into an exacerbation. You also have to remember, if you have other heart disease, if you have heart disease or other diseases, they may be playing a role as well. But there's no real rationale as to why one is different than the other than that we just perceive our symptoms differently and report them differently too.
And my main question is about the new gold standards from the meeting that just recently happened. I assume you were there. David Menino posted on Twitter curious guidance from COPD Gold 2022, ICS, inhaled corticosteroid containing therapy, not really recommended in exacerbating COPD, even though it's the only pharmacological therapy that may decrease mortality.
Right. In COPD that is stable, then and you have significant symptoms and you've had more than one exacerbation in the last year, then triple therapy, the inhaled bronchodilator, the long-acting beta agonist, and long-acting muscarinic antagonist, or the triple therapy is probably the way to go. Inhaled steroids for mild, well, I can't say mild COPD, I'll get myself in trouble there. If you have inhaled steroids and you have some symptoms and you haven't had an exacerbation, probably shouldn't be used overall. And certainly with an exacerbation, steroids they should be used. Oral steroids, not inhaled steroids, oral steroids. Now, some people ask, do you take people off the inhaled steroid while you're on an oral steroid? If you're in a hospital, I typically do. If you're at home, I just stay on your same inhaled medication, and add the oral steroids for a very short course to that overall. Yeah.
With no taper, correct?
With no, I don't taper. I go 5 to 7 days and then just stop. Yeah, for 40 milligrams of prednisone for 5 days, 7 days should be more than enough. If you're not getting better within a couple of days of that, then again, you need to call your primary care provider back,
Right.
because it could be something else. It could be heart failure. It could be pneumonia. It could be some other type of comorbid condition that's causing you not to get better overall. And that's why the action plan is important, because that'll be included in your action plan. So if you have concomitant heart disease or heart failure and COPD, it's difficult to figure out which is causing the problem.
Thank you.
If I could add to the action plan statement, having done home care, sometimes if people really aren't feeling well, it's hard to put all the pieces together. So I'm assuming that in any action plan anybody has, it's going to be written down in detail, phone numbers of emergency contacts, list of current medications, and put that on your fridge. Stick it right on the front of your fridge.
Yep.
I'm assuming that's what people are doing, but we may have some folks that are new on the call, and all of those things need to be there, because if you're feeling really horrible and you're struggling to breathe, all of that stuff might not be coming to your mind right away because you're thinking about breathing. So put it right up there. All of that information needs to be handy. And if you end up calling EMTs, they're going to need that.
But
God forbid
the
you
quicker you
have to,
react, the less chance of being hospitalized.
Yeah.
Exactly. But you know what? If you have this stuff, it's like insurance, John. You hope you never have to use it, particularly life insurance, you know? This is basically like part of your life insurance in many ways. It just to have it, because if you didn't have it, you wished you had. So
And nowadays with the cell phone apps that are out there, like I said, the COPD Foundation app, that's all included in that. So your history, your medications, those type of things. In fact, you can get them for your watch. So there's a little watch band. It's like a medical alert tag that you can get onto your watch that has a QR code on it, that when you go to the physician's office, they can download all your information out there. So if you're sick at home or you're by yourself and you're worried about, when the EMTs come, they're not going to look at your refrigerator. However, they will look in your wallet, they'll look in your purse, and they'll look at your watch now. So those are all available, and they're $10 online, if that. COPD Foundation thing's free. That you can just get on there and get the app. And then when you go, and in fact, you can actually measure yourself on there, because pretty sure they have the COPD assessment test on there as well. So you can actually, record how you're feeling on a daily basis, for those of you that are that anal, that want to do that every day. John's laughing out there, but I think, you'll know. And after your first exacerbation, I would venture to say that you're going to know what it feels like the second time, the third time. Hopefully you won't get to a fourth or fifth time, but you'll know it's, hey, this feels like what I had before. Maybe I need to implement this plan that I've worked out with my healthcare provider. Yeah.
I also want to recommend the health app on your iPhone, because a month ago I was carted out by the EMTs to the ER and then ICU. Turned out, because my carbon dioxide reading was 107 on the arterial blood gases, but I couldn't speak, couldn't breathe. I just handed the EMT my phone, and I have the health app open, the medical summary. It gave them all my meds, my immunizations, all the info they needed, height, weight, everything. So if you keep that up to date, that's also a good source of info.
Yeah, Phyllis, you have a question. Oh, you're on mute.
Yeah, I know. I just
take your
wanted
screen
to
sharing
circle
off.
back on John's question about the female and the males, females having more symptoms. And I was just wondering if that has anything to do with females having a smaller body mass as well as smaller airways. Is that possible?
Not that I know of. Not that I know of. No, just the way it's just reported. And
Okay.
yeah, and I liken it to, like you said, heart attacks, that, women and have atypical chest pain, not the standard, substernal chest pain that radiates in the left arm. Women might just say, I've had a little bit of chest discomfort, and it's really an acute heart attack.
Yeah, and sometimes back pain as well with the heart attack. So yeah. Okay, thank you.
Let's see. Let's go. Christine, you have a question. You want in the chat too, I think.
Yep, exactly.
Yeah, I just wanted to know if you could stop sharing your screen so we could see everybody, just because it's nice to see everybody.
There you
Thank you.
There.
Got it. Okay. There you go.
Yeah. I did have something in the chat. I don't remember what I wrote.
About sniffles and feeling run down, consider an exacerbation. Could be. Yes. Yep. And you said also, isn't COVID an exacerbation in itself, like a cold or a flu? It is. I mean, it's not considered to be an exacerbation. It's just considered to be COVID. I mean, it's like a flu. Well, it is a viral infection, but it's interesting that when COVID was out there, very few, the exacerbations that required hospitalizations dropped significantly. Why that is, I think it's all because, everybody was paying attention to, good hygiene skills and not getting exposed to other people that were out there that had a cold or a flu. I think we'll see that transitioning back this year. I suspect that we're going to see an increase in the influenza virus this year, because we are not as how you want to complain, or we're much more complacent about, hand washing and masking and things like that right now. I mean, I was on an airplane last week. 2 people out of the 200 people on the airplane had a mask on.
Yeah, we're
mean,
less hypervigilant. We were hypervigilant at the height
Yeah.
of it. Now
Yeah.
that's kind of toned down.
Yeah. So let's see, Star, you want to go next?
Sure. I never know if I'm having a flare up or I'm having an infection because I have allergies. So if I'm, working in the dust, say, I'm going to be more short of breath and yada, yada, yada. I never really run a fever. It's sort of a low grade, but there's sometimes I know when I'm sick, I'll wake up and my bronchial tubes will be distressed. It's like I'm feeling cut glass in there. I'm swallowing cut glass. And if I let it go, my bronchial tubes, because I have asthma and emphysema, but my bronchial tubes will just close and can't breathe, can't speak. And if I don't, right away get on the antibiotic and the prednisone, I'm going to end up in the hospital, as I did once. So now I know, but I'm always wondering, it starts out shortness of breath, not feeling well. Is it a flare up or am I going to get an infection?
Well, it's a flare up. It's certainly a flare up or an exacerbation. Whether you're developing an infection on that, now the infection could be a viral infection, but if you're talking about a bacterial infection, that would be probably more in the way you probably will maybe have a higher fever, maybe have sputum discoloration, but it's hard to tell. It's hard to tell one from the other. And that's why most care providers out there will start you on an antibiotic early on, in addition to steroids. But yourself best. You've described it here that I know that I'm getting this. When you're getting that, then I would work with your primary care provider to have the plan and tech. What am I going to do? What am I going to do in day 1, day 2, day 3? When do I call? For example, on day 1, you might want to just change to an aerosol bronchodilator as opposed to your inhaled therapy. Or you might want to add a steroid on early on. Or add the steroid on early on. I typically tell people, here's steroids, keep them at home. If you get this symptom, start the steroids right away. You don't need to call me at 9 o'clock at night, but you need to start the steroids. Call me the next day, and then we can discuss it the next day. Something like that.
When you say steroid, you mean the prednisone?
Prednisone, right. Yeah, prednisone, a prednisone pack, or 40 milligrams of prednisone a day. That seems to be, there's a lot of different variability. If you talk to 100 physicians out there, you'll get 50 answers as to what the right course of prednisone is and how much. Typically, it's 40 milligrams for 5 days and maybe 7 days, but 5 days is what, and then just stop it after that.
Are you familiar with this symptom I get where it feels like my throat, I'm swallowing cut glass?
Yeah. It's just a sore. You just got to. Yeah, that's your manifestation of what other people would say is a sore throat. Yeah, sore throat and airway inflammation that's there. But the fact that you get better when you started on the medicines is what I would use the second time around or third time around. And realistically, you shouldn't be having more than one exacerbation every couple years or so. Ideally. If you had an exacerbation within the last year, then you really want to review over with your primary care provider what would be a better regimen for your standard therapy.
So if it starts with the cut glass in the throat, you're saying that probably is the sign of the flare up that can lead to the bronchial infection.
Yep.
Am I saying that right?
Yes. Yep. Absolutely.
Let me just tag on to her question real quick before we go to Art, whose hand is up next. What antibiotic would you prescribe along with prednisone for someone that is already taking azithromycin as a prophylactic?
Probably in that case, almost anything, John. Almost, Augmentin seems to be where. I mean, if this goes back 40 years, Augmentin, doxycycline, and erythromycin, or now we use azithromycin.
What do you think of Bactrim?
Bactrim's a good drug as well. Yeah, Bactrim's a good drug. I typically go with doxycycline because that'll cover some of the atypicals, or particularly if somebody has an allergy to penicillin. And if you look at the guidelines, the new guidelines, they don't say which antibiotic to start.
Yeah,
because we don't know. We don't know which one is.
I had been prescribed Levaquin And
Levaquin's
I'm-
another good drug.
But then another doctor told me that it can put holes in your aorta.
It can do that. It can cause your Achilles tendon to
I
rupture.
know about that, but
Yeah, it can cause a lot of different things, but they all can cause a lot of different things too. Yeah, I've never seen the aortic aneurysm formation or anything like that. But yeah, but all these drugs, but they're the best ones we have available. The fluoroquinolones. Now, if you've had a bunch of exacerbations before, or you've had Pseudomonas before, then you should really be on a fluoroquinolone to start. So that would be, so if your doctor says, well, yeah, you've had Pseudomonas in your airway before, then I go with the fluoroquinolones first. Otherwise, I'll go with doxycycline or, Bactrim, somebody had mentioned, or even Augmentin. And Augmentin's an old drug. That's 40, 50 years old, and we're still using it today. Let's see. Yeah, see, Art, go ahead. You are not coming through there, Art.
Yeah, I don't know what's wrong with the sound. You're not muted.
Check your microphone, Art.
Or you can just type it into the chat. We can get to it that way too. And in the meantime, I'll answer Ty's question about exacerbations cause permanent damage. They probably do. They probably do. Each exacerbation you get, there's more damage that's done to the lung. Fortunately, as most of us have a way in excess of lung function available, it's not till you get really down significant decrements in your lung function before it really impacts you overall. But if you're already working on, and have severe COPD, every exacerbation begets more damage to the lung themselves, whether it's in the airways or it was often felt it was just in the alveoli, but it may be in the airways as well, particularly if you have underlying asthma as well. I see Art madly typing here.
while he's typing, is it fibrotic damage? I mean, you get more fibrosis because of the exacerbation, or what type of damage?
Well, you can get all sorts of things, John. You can get fibrosis of the alveolar or the interstitium. You can get actually impaction of the airways themselves. This would be more somebody that has an asthmatic component to it. But the mucus glands are disrupted, the cilia are disrupted, the alveoli are disrupted, and then the interstitium's disrupted. So everybody gets a little bit different, process out there. And that's one of the things they were talking about at the meeting the other day, where they had, interstitial lung disease and COPD together. We just don't know. We just don't know, because when most people die from when they die, most people don't get autopsies. So we're not looking at what happens pathologically to the lung. About as best as we had is when people were getting volume reduction surgery. So when they would go in and people would electively choose to have part of their lung, removed, then they would look at that under the microscope. They'd see all sorts of damage. And I forgot to mention damage to the blood vessels too. So there's vascular blood vessel damage, but it's mostly damage to the mucoid glands, the cilia, and the alveoli that are damaged. Let's see.
Art, you want to try again and see if your microphone is working? If not, we'll have you type in. Yeah, I don't know why we're not here.
I think it's working. It's working now, Art, I think.
You got it working?
I'm not hearing it.
I saw the
Well,
yellow.
he's working on that. I get into Ty's question. He says bronchiectasis is possibly a result of an exacerbation. We don't know. It's a great question. Bronchiectasis probably, there's probably a congenital component. Well, there is a congenital component to it, certainly. And we see all sorts of infections that are associated with, not all sorts, we see some infections that are associated with bronchiectasis, like for example, Mycobacterium avium in women. has been associated with bronchiectasis. Why that occurs in women, we don't know. It's genetically, it has to be genetically regulated in that instance. But bronchiectasis being one of the really 3 or 4 types of COPD, if you look at chronic bronchitis, emphysema, asthma, bronchiectasis would be the 4th type of COPD out there. And there's a lot more being learned about that every year. Probably not the result. I mean, you can get, if you get a pneumonia, in fact, we'd see bronchiectasis occur like if you had a pneumonia as a kid. Let's say you were unfortunate, you aspirated a peanut when you were 5 years old and you got a focal pneumonia in one area of the lung. Then you are at risk for developing bronchiectasis in that area of the lung. And what happens then is that you're bothered by increased sputum production or mucus production, possibly the rest of your life overall. But as far as, I think that there is some bronchiectasis that does occur in areas. So you get pneumonia, you get COPD, have an exacerbation, develop a pneumonia, and it's in one of the lobes of the lung, then that lobe of the lung can develop bronchiectasis. And we see that fairly frequently overall. The next question, Art, do IPF exacerbations exist? Absolutely, absolutely. And they are much more devastating than is a COPD exacerbation for most people. So if you have IPF, you really want to get an action plan in place and get started on treatment very, very early. And the reason I say that is most people with IPF, by the time it's diagnosed, are significantly ill from that disease, and they've lost a lot of lung function already. So one of the things you want to do is try and preserve the lung function as best you can, but typically treated the same way, typically treated with steroids, higher doses of steroids for, we don't know the dose overall. It's not like you want to take 40 milligrams of prednisone for 5 days. You probably want to be on a 10 or 14 day course of prednisone along with antibiotics as well. And many people, interestingly, will develop, when they develop the IPF exacerbations, they're put on aerosolized bronchodilators. I don't think that necessarily will help you because, again, the interstitium is not responsive to bronchodilators, but we don't know. I mean, do we know? There's never been studies done in it. And do the inhaled steroids help IPF exacerbations? Who knows? Who knows? I know if you come to the hospital and with an IPF exacerbation, you're probably going to be on an antibiotic, on a steroid, and on aerosol treatments, just because we do the latter. But I'm not sure that that is really all that beneficial overall. So let's see. Tom has a question there about, can the vest be used for COPD? If you produce sputum, the answer is yes. If you are not producing sputum, and you have, let's say, a pure emphysema, you don't have any bronchitis at all, then a vest is probably not going to be helpful for you. You could use it, probably can't get it. You probably can't get it covered by Medicare. But if you do produce a lot of sputum, you have chronic bronchitis or certainly bronchiectasis, then vests are a good way to go. And you have to work with your healthcare provider to get you one and get one prescribed or get one covered by your insurance plan. But the insurance plans are pretty good about getting them for you if you have a sputum production, you qualify for it, and they're very, very helpful. They're very, very helpful.
So I'm just recovering from COVID also, and I got more mucus, but it's very hard for it to get rid of it. Mm-hmm. And I do have a vest, and it doesn't seem to help a whole lot.
Well, if you have a lot of thick mucus, then the vest will not thin that out. So you want to get on some type of mucolytic therapy at pretty significant doses. So like guaifenesin, there's some other aerosolized mucolytics out there. The data is plus minus. I always tell people, if it helps you, great, try, keep using it. If it doesn't help you, stop using it. But I would use a mucolytic along with the vest itself. The vest will just will help move it up. Whereas the mucolytics help thin it out. And that's one of the problems that you get into when you get, this mucus gland disruption, that the mucus just isn't moist enough and overall.
And what is that called? What kind of?
Guaifenesin, Mucinex.
Oh, I
Yeah.
do use that, yeah.
Yeah, but you want to use fairly high doses of it, like check with your primary care doc. But you want to use not just 600 milligrams once a day, probably 1200 milligrams 3 to 4 times a day is what I tell people to do.
Okay.
Yeah.
Thank you.
Let's see, the next question, Star, recommend air purifiers for COPD and asthma. I think they're helpful. I don't recommend it for everybody because the cost is, $300 usually at a minimum. You can get some cheaper ones out there. You want to get a good one if you're going to get one. So get one with a HEPA filter in it. And they're, I was looking at these the other day just for myself for other reasons, but they're between $300 and $700 overall. You don't want to buy one of the $50 ones they're not going to help. But certainly if you're in an area where there's a lot of air pollution, a lot of pollens, I think they can only help.
Unless it's one that produces ozone, then it's probably not so good.
Right. Yeah. The ozone ones, that's a good point. I forget about those. Yeah. Yeah. You just want to use there's a whole bunch available on the market. Dyson probably has one of the better ones out there overall, but they're also upwards of $800-900.
Yeah, and blue air or something, they're very, very costly, but they're good.
Yeah. Let's see. The vest hasn't helped as much as aerobic with a nebulizer. Yeah. The other thing too is the devices that basically create a flutter valve. Aerobic is a great one out there. And there's other ones out there. Aerobic is a little bit more expensive than some of the other ones out there, but a flutter valve is also helpful. Tom, if you were going to use a flutter valve, you would need to use it with a mucolytic as well, if it's really thick. But aerobic will help out there. And then Ty mentions about 7% sodium chloride as well. Yeah, you can use it. That'll get you thinning some mucus out and mobilizing mucus. But you want to talk with like I said, there's 4 or 5 different brands of flutter valves out there. The hospitals typically will use the cheaper ones, even though I think the aerobic is probably the best one out there overall.
That's where I got mine. Here's the aerobic.
Yeah, it's nice you can hook it into your
I feel
aerosol.
like Carol Merrill on The Price is Right.
Yeah, there you go. No car though, huh, John?
Got no car.
Yeah.
No car for you.
Yeah.
Yeah, interestingly, and if you think if you folks might be interested, there's a company that I've been talking to that has a good and a newer air purifier, and they were interested in potentially coming to speak. So if you guys think it would be something, you'd at least talk about the science behind it, and of course they're going to talk about their product at the end. But I told them if they're going to come talk, you got to provide us some very real education, and then if you want to talk about your stuff at the end, sure, but you got to teach us something. So.
Yeah, I think Christine brings up a good point too, as she mentioned that Dyson tested poorly in Consumer Reports. Yeah, a lot of these things are out there, and you just comparing one versus the other is to me is very difficult to do. The best one that works is the one that works for you, but you don't want to invest like $500 in something and then say, oh, it's not that good overall. So I think, Joe, that'd be great to have somebody come on and then sort of give us the down and dirty from their perspective. I mean, we'll obviously get their bias.
Right.
But then again, there's a lot of biases out there for all the different companies out there.
In some purifiers, you install in your basement or wherever your actual system is that are entire house purifiers versus a room purifier.
Yep.
Yeah, well, that'd be the ideal thing. But you're talking several $1,000s, I imagine.
I have no idea. I'm not going to do that, but
yeah, that's ideal because you don't live in one room of your house.
Right.
I mean, and you can't take the purifier from one room to the next room to the next room overall. I think that they're very helpful overall. Like you said, John, that's the best way of doing it. Just get a whole house purifier on your HVAC system.
Yep.
And then make sure you get your vents cleaned.
Replace the filter.
Yeah. Cool. Oh yeah, Ty saying purifiers are help with that's a great point, right? Like Dr. Brian said, if you're in a place where there's a lot of particles in the air, pollution, whether it's natural pollution, if you want to call it that, from wildfires, or whether it's, you know, man-made pollution, whatever you want to call it. Either way, it's, you know, if there's junk in the air, you want to clear it out and try to keep yourself from breathing it in.
Yeah. And the problem is too, is even though I'm in the East Coast, we had, you know, smog here from the wildfires in Montana and Idaho last year. It just got in the atmosphere. They came to the East Coast, and there were a couple of days where the air or the pollution counts, or whatever you want to call it, were very, very high, and they recommended people staying inside. And that's where for most of you that have air conditioners, that's where those will play a role.
Excellent. I see. I don't see any other additional questions in the chat at the moment.
Vicky, you usually have a question. See, I'm picking on you. You don't have to.
This was great though, Brian. As always, you know, it's why we love having you here, because you always have just an unbelievable amount of education that is always very helpful and relatable at the same time.
Well, hopefully it helped out a little bit there, so somebody doesn't get their exacerbation. And if you've had one in the last year, talk to your primary care doc or talk to your healthcare provider about what else you can do to prevent them. Because certainly, and what I see commonly is that you know, people are on, and I won't pick some of the medicines out here, but they're on albuterol, Atrovent 4 times a day still, and they're having exacerbations. Not the best drug. Not the best drugs. They're great drugs, but you want to get them where you're on double or triple therapy, because those drugs are much better now than we had back years ago. So, and you want to also make sure, if you're getting an exacerbation, make sure that they've actually diagnosed you the correct way. I've seen plenty of people out there. We see in the hospital all the time. They said they have COPD and they're not getting better, and lo and behold, they have an ejection fraction of 25%. And they have heart failure in addition to their COPD. So until you treat the heart failure and the COPD, you're not going to get the person better.